Brought to you by Dr. Joe Ordia. Frequently asked questions about neurosurgery and pain management. Questions 81 to 85. Peripheral nerve stimulation for chronic headache. I start with a disclaimer. The opinions expressed here are for general information and based on my own professional experience. They are not intended to replace the advice of your healthcare provider on your particular condition.
Question number 81. What is peripheral nerve stimulation?
Answer. Peripheral nerve stimulation, PNS, is the use of a medical device to deliver controlled electrical impulses to targeted peripheral nerves to relieve chronic pain. The central nervous system, CNS, consists of the brain and the spinal cord. Peripheral nerves connect the brain and spinal cord to the rest of the body, such as the head, organs, and limbs. PNS is still evolving, and some stimulators are non-invasive and external. Significant strides have been made with implantable PNS for treatment of chronic headache. The mechanism of action of PNS has both peripheral and central components. Peripheral nerve disorders can increase prostaglandin levels, causing dilation of blood vessels, local inflammation, hypersensitivity of nerves, and trigger attacks of pain or migraine. The peripheral effects of PNS involve suppressing prostaglandin release while enhancing the secretion of endorphins, the body's natural pain relievers. The central mechanism can be explained in part by the gate control theory of pain. Stimulating the peripheral nerve activates the gate control system in the spinal cord to suppress the pain signals from small diameter nerve fibers from reaching the brain.
Question number 82. Thank you so much for talking about headache and migraine. Some of my friends have migraine and I can see how much they suffer when they get an attack.
Answer. You are very welcome. Chronic headaches are common medical conditions worldwide. A significant number of these are migraine, which is a primary headache disorder. The World Health Organization, WHO, estimated that in 2021, about 40% of the global population had headache disorders. Tension-type headache was the most frequent at 26%. Migraine accounted for about 14%, and cluster headache 0.1%. Chronic daily headache occurring on 15 or more days a month was about 4.6%. The prevalence of chronic migraine was about 2% of the global population. Medication overuse headache, also known as rebound headache, and caused by frequent use of medication to alleviate headache, was 3% and was the most common secondary headache disorder. Additional information at https://who.int/news-room/fact-sheets/detail/headache-disorders. Migraine headaches are among the leading causes of years lived with disability. Most migraine headaches are episodic and occur less than 15 days per month. Chronic migraine is defined as headache occurring at least 15 days in a month for 3 months or longer, of which at least 8 of the days have features of migraine. The features may include aura, throbbing head pain, light sensitivity, photophobia, sound sensitivity, phonophobia, nausea, or vomiting. The prevalence is equal in males and females during childhood, but after puberty, it is more common in females. Women are 3 times more affected than men, largely linked to fluctuations in estrogen. Migraines are most prevalent between ages 18 to 44. Aggressive treatment of episodic migraine is vital to reduce the risk of progression to chronic migraine. About 2.5% of people with episodic migraine progress to chronic migraine each year. They are more difficult to treat, and the risks include anxiety, depression, and sleep disorders. Some experience stigmatization and social isolation by people who may not understand how debilitating migraine headache can be. Decline in work performance often results in financial difficulties.
Question number 83. What treatments are used to control episodic migraine to prevent them from transforming to chronic?
Answer. The effective treatment of migraine requires the integration of two strategies: preventive treatment to reduce their frequency, duration, and severity, and abortive treatment to relieve the symptoms of an acute attack. Migraine triggers are not the underlying cause, but are stimuli or events that can set off or aggravate an attack. Limiting exposure to triggers can mitigate migraine attacks. They vary by individual, but common migraine triggers include emotional stress, physical overexertion, sleep disturbance, and hormonal fluctuations, especially menstruation. Food triggers include excessive caffeine, MSG, and skipping a meal. Alcohol and nicotine use can be triggers. Environmental triggers include bright or flashing lights, loud noises, strong odors, and high altitudes. Preventive or prophylactic medications are sometimes prescribed. Acupuncture has been helpful for some patients. Botulinum toxin injection given every 12 weeks is FDA approved for some chronic migraine. Abortive treatments are taken at the onset of a migraine. They include over-the-counter pain relievers such as ibuprofen, acetaminophen, aspirin, Excedrin migraine, as well as prescription medications. Information about individualized treatment and medications for preventive or abortive treatment and their potential side effects are best discussed with a neurologist or headache specialist.
Question number 84. Which patients are suitable candidates for peripheral nerve stimulation?
Answer. Peripheral nerve stimulation, PNS, may be considered for patients with disabling chronic headache that is refractory to lifestyle changes, medical and interventional management. PNS is mostly beneficial for chronic migraine, cluster headaches, occipital neuralgia, chronic daily headaches, and hemicrania continua. Psychological screening is required before the trial. Proactively managing any associated mental health issues such as anxiety, depression, and sleep disorders can enhance the effectiveness of PNS. The purpose of a PNS trial is to determine the effectiveness before committing to permanent implantation. The percutaneous lead is often used. Under mild sedation and local anesthesia, using a special spinal needle and fluoroscopic guidance, the temporary lead is passed in the subcutaneous layer across the area of the target nerve. The lead is connected to a trial stimulator via a trial cable. Intraoperative testing is performed and the feedback from the patient helps to fine-tune the optimal placement for full paresthesia coverage. The cable is discarded, the externalized proximal part of the lead is secured to the skin, covered with a sterile dressing, and connected to a trial stimulator. Prior to discharge, several programs are added to the stimulator, and the patient is taught how to use the remote control. The duration of the trial is variable, but commonly 7 to 10 days. A reduction of migraine pain intensity of at least 50% is considered to be a successful trial response. Percutaneous leads are pulled out at the office following the trial.
Question number 85. Which peripheral nerves are commonly targeted for stimulation in the treatment of chronic headaches?
Answer. The greater occipital and trigeminal nerves are the main targets for stimulation. The greater occipital nerve supplies the back of the head and enters the spinal cord at the level of the second cervical spine, C2, while the trigeminal nerve innervates the forehead and face. Both nerves connect at the brainstem, trigeminocervical complex. The trigeminal nerve is the fifth and the largest cranial nerve and has 3 branches. The ophthalmic nerve, V1, provides sensation to the forehead, upper eyelid, conjunctiva, cornea, and nose. The maxillary nerve, V2, primarily provides sensation to the lower eyelid, conjunctiva, cornea, and middle third of the face. The mandibular nerve, V3, has both sensory and motor functions. The sensory supply is mostly to the lower face, lower jaw, and anterior 2/3 of the tongue. The motor fibers innervate the muscles of mastication. Along with Dr. David Dodick of Mayo Clinic and Dr. Stephen Silberstein of Thomas Jefferson University, both esteemed migraine specialists, I was one of the investigators in a randomized multicenter, double-blinded, controlled study of PNS, of the occipital nerves for chronic migraine. The one-year results were published in 2014. They provided valuable insights into the safety and efficacy of the therapy and key practices for achieving optimal treatment success. Additional information at https://doi.org/10.1177/033310241445433331. There are different options for permanent implantation. I will describe the technique that I have found to be effective. Under general anesthesia, the patient is positioned prone. A local anesthetic is applied and 2 small skin incisions are made, one overlying the spinous process of C1 vertebra and the other just behind the right mastoid process where a subcutaneous pocket is created. With fluoroscopic guidance, a lead is tunneled subcutaneously with a special spinal needle from the midline, laterally towards the left mastoid process and perpendicular to the greater occipital nerve. Lead migration was the most common hardware complication in earlier studies using 4 electrode leads. The 8 electrode leads have a lower revision rate. The lead body is tunneled from the midline to the right retromastoid pocket. The midline incision is closed and a sterile dressing is applied. A second lead is passed subcutaneously from the retromastoid incision towards the midline and perpendicular to the right greater occipital nerve. Each lead is anchored to the fascia and placed inside the pocket. The skin is temporarily closed and covered with a sterile dressing. The patient is turned supine and the head is rotated to the left. The temporary dressing is discarded and the wound is opened. After preparing the field, a local anesthetic is applied, an incision is made below and parallel to the clavicle, and a subcutaneous pocket is created. The 2 leads are tunneled from the retromastoid wound to the infraclavicular pocket. The pin connectors are attached to the generator and normal impedances are confirmed. The generator is placed in the pocket, both incisions are closed, and dressings are applied. Post-operatively, programs are entered into the generator, and the patient is taught how to use the remote control. For a rechargeable generator, charging instructions may be provided prior to discharge or at a follow-up visit. The generator could be implanted in the abdominal wall or upper gluteal region instead of infraclavicular. However, the longer distance causes greater mechanical stress, increasing the risks of lead migration or breakage. Variations of the surgery are possible. Unilateral migraine may respond to one occipital lead. Some patients with cluster headache or hemicrania continua, which are often associated with facial pain, accompanied by lacrimation and nasal congestion, have a good response to one occipital lead combined with one supraorbital lead. The incision for the supraorbital lead insertion is made vertically, above and lateral to the eyebrow, behind the hairline when feasible. The lead is passed subcutaneously across the nerve and the lead body is tunneled to the retromastoid pocket, anchored, routed to the infraclavicular pocket, and connected to the generator. The incisions are closed and dressings are applied. Follow-up visits are important for programming and ongoing management.